Hello, I'm Guitera, and I would like to present today about new and small invasive melanoma, a common occurrence in tertiary practice, and what tools can help us. I'm working at the Melanoma Institute Australia, the University of Sydney, the Sydney Melanoma Diagnostic Centre at Royal Prince Alfred Hospital. So I would like to take a step back and talk a little bit about the role of dermoscopy monitoring and total body photo in the follow-up of our high-risk patient. And then I will come back to this question of overdiagnosis. Do we need to come back to 6 mm rule, like some author of the New England Journal of Medicine have proposed to tackle this problem of overdiagnosis? Then I will show you the result of our study on small and new melanoma and also how the AI tool performed. And then I will try to give you my conclusion on what I've learned and what I'm still learning. So the role of sequential digital dermoscopy imaging, SDDI, in melanoma diagnostic have been well established more than a decade ago. And we know that we can detect suspicious dermoscopic change in lesions that lack dermoscopic evidence of melanoma. And basically, even if it lacks any feature that are well known of melanoma on dermoscopy, if it's changing in 3 months, it needs to be removed and most likely melanoma. If it's not changing, it can be safely monitored. So 6 months or more long-term monitoring can be used also in particular for lentigo maligna that is changing slower, and it's convenient in our lower risk patients when we don't see them all the time. But in that case, you need to distinguish the suspicious melanoma feature from the non-suspicious change. It can be used in primary care and specialist context, and it can also reduce the number of patients referred for biopsy, so not only a better sensitivity, but also a better specificity. The level of evidence is quite high with level 2 evidence. The role of total body photo in melanoma diagnostic is a little bit the same, even if the evidence are lesser with level 3 evidence. It's especially useful in high-risk patients because we find not only not only skin cancer, but also melanoma. And we can also detect very early melanoma that have no feature of melanoma on dermoscopy. And it may also reduce the number of nevus biopsies, so better specificity. We have shown in a very high-risk population that when you use this total body photo and SDDI regularly, you can have fewer excision and also a lower cost for your patient. We have also shown that it was not just in our hand, but also in primary care practice and other practice, with around 30% of melanoma that are only detected by image. So let's come back to this question of small melanoma and if we should come back to this 6 mm rule. So because of that, we've chosen arbitrary to have a look at all our melanoma in the last 2 years on the retrospective design that were less or equal to 5 mm. And as you can see on this photo, some melanoma that are 3.2 mm are already 0.94 mm breadth of thickness, so quite nasty nodular melanoma that will most likely kill your patient in a few months if you don't detect them early stage. That have been published by Dr. Amanda Reggio Pereira, and I will summarize some of the data. So one thing that was important was to really define what was clear melanoma, everybody agree, but what was a borderline melanoma. So for our borderline melanoma, we review with at least 2 pathologists and 1 senior pathologist. I review all the slides and use a checklist to really have strict criteria in between what was mild, borderline, and clear-cut melanoma. So he defined borderline as focal severe cytological atypia, near confluent growth, central suprabasal scattered of cluster of melanocyte or occasional small melanocyte, increased atypical junctional melanocyte in severely sun-damaged skin with extension down the adnexy. And also very important, all these lesions have been managed as melanoma with a Wilder excision during our clinical pathology correlation time, that is every Friday morning into the multidisciplinary meeting. So the result. We found that 27.6% of our melanoma were less than 5 millimeter. With this strict review of pathology, 50% were borderline, but 44.2% were already invasive at this size. 78% were found only on the image, SDDI or TBP, because they were new or changing, we removed them, and 21% because dermoscopy was atypical. Interestingly, tiny melanoma were more frequently having this starburst pattern, 14%, or globular pattern, 10%, compared to non-tiny melanoma. More importantly, the dermoscopy predictive feature of invasion were atypical vascular pattern, and the odds ratio was 26, so quite a potent criteria, this atypical vascular pattern. You have an example there on the knee of a 40 years old something that is very small, 2.5 millimeter, but already 0.2 millimeter bursal thickness. And you can see on this photo also the shiny white line that had an odd ratio of 12 for invasion on our series. Gray-blue structure was also an odd ratio of 3 and important for the prediction of invasion. We know that gray and blue mean the melanin is deep, and of course, we don't have always time to think about this lesion. They may need to be removed urgently. So, investigating new acquired lesion was a normal sort of next question. We wanted to know if they were the same than the small melanoma, and also to compare with a control cohort of melanocytic navy. Dr. Amanda Pereira lead this study also, and it was done with total body photo as a baseline where we can see the lesion was new. So it was an objective way to know it was new. We found that in this cohort, 43.3% were invasive and 40% were borderline. So quite similar cohort and quite frightful cohort also. In this table, you can see the nevus, the borderline, and the clear-cut melanoma that we put apart. And you can see the median size at diagnosis in millimeter was 2.6 millimeter for the nevus, 3.2 for the borderline, and 4.4 for the melanoma. So most likely telling us something about the biology of this lesion. We can see also the mean age of, at the time of diagnosis, was 46 for the nevus, 54 for the borderline, and 56 years old for the clear-cut melanoma. And the age seems to be playing a major influence on what you can monitor and what you should remove. 75% of new melanoma would have been missed by the 7-point checklist method. So most of this melanoma had no dermoscopy feature whatsoever and have been found just because of baseline photo. Then at this time, I was at the Memorial Sloan Kettering doing a sabbatical, and I want to thank Professor Alan Appen for his wonderful welcoming. And of course, I was collaborating with Veronica Rottenberg, with this world experts in artificial intelligence for the diagnosis of melanoma. And so she asked Emily Cohen, one of her students, to have a look at the series of MSK. And they found that they had a lot of tiny melanoma also in their series of 1 year in 2020, with 24% of the melanoma that were tiny, so not far from our series. And she also found that the algorithm they're using at MSK, that is called ADE, that win the last ASIC challenge, so it is a very good algorithm, were degrading when used on tiny melanoma compared to non-tiny lesion. And then they had a look at new lesion, and they found that first, they didn't find new lesion, because when Emily had a look in the file, what was said to be new lesion was not new on the total body photo. And she didn't have enough total body photo to be able to really put a series together. So she gave up, and she's just taken our series of cine and compare with non-new lesion. And you can see the new lesion AUC curve there is really bad compared to the non-new lesion. So I think if we were to give the algorithm some metadata about the fact that it's new, or about the diameter of the lesion, or about the age of our patients, most likely the algorithm could sort of shift their sensitivity and specificity, taking that into account and allowing this tool to be very useful also for difficult lesions that are with not much morphology feature that the algorithm can rely on. So what I've learned already that in a high-risk population, the tools are very useful. And I want to repeat that we don't do total body photo and monitoring for all our patients. We just do that for the high-risk patients. But for this guy, it does help, because it's the way we found 30% of our melanoma. And it's also true in Australian primary care. Do we need to ignore small lesion to avoid overdiagnosis? No. 44% of the small melanoma and 43% of the new melanoma were invasive. And were new and small cohort contain more invasive than the rest of the melanoma we diagnose. I guess it's also because in cine we diagnose a lot of lentigo maligna, in situ melanoma, that are of course very large and not new. New melanoma compared to total body photo are the real way of knowing they're new, because what the patient say or the doctor collect in their notes is maybe not exact. New and small overlap, for sure, they're a little bit the same cohort, 48% of the small melanoma and 75% of the new melanoma had no official, well-described dermoscopy feature of melanoma, and were quite inconspicuous. So what I'm learning, yes, 50% are real borderline for the small and 40% for the new melanoma. So they may be in this envelope of overdiagnosis. The median age of our patient with new melanoma was 9 years older than the patient with new navy. And this is something I'm computing nonstop when I see my patient now, to sort of decide if I want to monitor or to remove a lesion. I use the photo, total body photo and monitoring, but we know dermoscopy and pathology are sort of based on morphology and are losing us. Maybe biologically active change are better to be detected, because more than 40% were invasive. Overdiagnosis and borderline lesion need pathology correlation, and I do think it's excellent to be working with our pathologist colleague in multidisciplinary way, and ultimately we will need a better biologic marker to really chase this indolent and aggressive thing that looks the same at an early stage. We may need to change our AI threshold according to size and age. So this is my conclusion, and I would like to thank this Two amazing team, in particular at MSK, Dr. Veronica Rittenberg, and at Cine Melanoma Diagnostic Center, Dr. Amanda Reggio Pereira. I would like to thank the patient and, of course, you for your attention. Thank you.